Welcome to this video on the respiratory system, focusing on the pathogenesis, diagnostic gold standards, and strategic management of obstructive airway disorders. Respiration involves a cascade of events, starting with pulmonary ventilation and alveolar diffusion. Gas transportation delivers oxygen via hemoglobin, culminating in tissue exchange for cellular oxygen replenishment and carbon dioxide removal. Autonomic control ensures airway regulation through bronchoconstriction and bronchodilation. Bronchial asthma is classified into three main types. Atopic or allergic asthma is an IgE-mediated hypersensitivity, often triggered by common environmental allergens. Non-atopic asthma lacks allergen sensitization and is usually triggered by viral infections or chemical pollutants. Finally, drug and occupational asthma are induced by agents like NSAIDs or industrial dusts and fumes. Asthma triggers vary widely, including indoor microallergens like dust mites and pet dander, outdoor sensitizers such as pollens and molds, and inhaled irritants like tobacco smoke and chemical pollutants are also common. Other triggers involve cold air exposure, strenuous exercise, stress, and certain pharmacologic agents like beta blockers. The pathogenesis of asthma involves T2 cell domination, triggering the release of inflammatory cytokines. This leads to an early phase reaction, causing acute bronchospasm, and a late phase reaction recruiting inflammatory cells. Repetitive cycles of inflammation drive airway remodeling, causing structural changes like smooth muscle hypertrophy. The symptom spectrum of asthma includes a spasmodic cough, characteristic expiratory wheezing, and subjective breathlessness or chest tightness. Major complications include status asthmaticus, atelectasis from mucus plugs, and respiratory failure marked by hypoxemia and hypercapnia. Asthma diagnosis starts with a detailed clinical history, focusing on recurring dyspnea and allergic history. Spirometry evaluates FEV1 and FVC, with reversibility confirming obstruction. Daily peak expiratory flow tracking quantifies diurnal variations, and bronchial provocation can confirm diagnosis when baseline spirometry is normal. Asthma management includes long-term maintenance with inhaled corticosteroids and leukotriene modifiers. Quick relief rescue primarily uses short-acting beta-2 agonists and anticholinergics for acute bronchospasms. Advanced therapies include immunotherapy, biologics like omalizumab, and thermoplasty for severe cases. Chronic obstructive pulmonary disease, or COPD, includes emphysema, the destructive model affecting alveolar acini. The pathology involves alveolar destruction and loss of elastic recoil, leading to signs like prolonged expiration. The secretory model is chronic bronchitis, characterized by submucosal gland hypertrophy and narrowing of conducting airways, with persistent productive cough. Lung function in susceptible smokers with COPD shows an accelerated, irreversible decline in forced expiratory volume. Over time, this decline passes critical disability thresholds, leading to significant morbidity and eventual death. The etiology of COPD centers on chronic toxic insults from tobacco and pollutants. This triggers cellular infiltration by immune cells, causing intense inflammation. A key factor is protease elastase overactivity, destroying parenchymal tissue. Alpha-1 antitrypsin deficiency is an inherited risk factor, leading to early emphysema. COPD diagnostics confirm obstruction via post-bronchodilator spirometry. Non-pharmacological management emphasizes tobacco cessation and pulmonary rehabilitation. Pharmacological treatments include inhaled long-acting bronchodilators, corticosteroids, and oral PDE4 inhibitors for exacerbation control. Bronchiectasis pathogenesis involves permanent airway dilation due to chronic inflammation and scarring. This leads to a vicious cycle of bronchial obstruction, impaired mucus clearance, pooling, and microbial colonization. Leukocyte-mediated damage through released elastases destroys the elastic cartilage. Common pathogens include Pseudomonas and Haemophilus influenzae. The clinical profile of bronchiectasis is characterized by a severe chronic cough with continuous production of purulent sputum, and sometimes hemoptysis. Systemic signs include breathlessness, fatigue, and nail clubbing. Diagnostics rely on high-resolution CT scanning. Management focuses on mucus clearance using chest physiotherapy and therapeutic interventions like targeted antibiotics and long-acting bronchodilators. These are the image sources used in this video. Thank you for watching.